And now I'm happy to introduce Dr. Whitney Buckel. Dr. Buckel will tell us about antimicrobial stewardship in community and rural hospitals. Dr. Buckel?
Hi, thank you so much for the introduction. So I'm excited to present to you today on antimicrobial stewardship in C. difficile because I think a lot of people kind of mentioned this, but I'll go into a little bit more detail about what this means. So I just gave a presentation. Okay. And that was supported by the Pfizer Grant for Learning and Change administered by the Joint Commission. And I was a co-investigator on that project. The primary investigator was Dr. Eddie Stenyam, who's unable to attend today, but I really thank him for all the hard work that he's really done to put this together. So my objectives today are to define antimicrobial stewardship, because I think it's something that a term we use a lot, but may be sort of nebulous to a lot of people. And also to give an example of an antimicrobial stewardship intervention that you could potentially do at your facility. So first, I just wanted to go over the national landscape for antimicrobial stewardship, because this has changed significantly in the last couple years. So before September 2014, there wasn't a lot in terms of stewardship in the national landscape in terms of like national policies. Really, there were some stewardship questions that were included on the CMS inpatient infection control worksheet, but these were really non-citation questions. And I think since then it sort of stepped up. So in September 2014, the president gave an executive order calling together people to combat antibiotic-resistant organisms, and they also submitted at that same time, or presented this PCAST report, which is the President's Council of Advisors on Science and Technology. So basically, a group of the nation's leading scientists and engineers outlined steps to combat antibiotic resistance. And this was further detailed with a specific national action plan that came out in March 2015. And really they're supporting strengthening antimicrobial stewardship, proposing, CMS, conditions of participation for stewardship, sort of similar to what they've done with infection control, as well as annual reporting of antimicrobial antibiotic use. And that's just one of, many different angles that they were recommending to combat antibiotic-resistant bacteria. In November of last year, there were actually proposed standards for antimicrobial stewardship by the Joint Commission, and these were released for public comment. And public comment ended the end of December, and so it'll be interesting to see how they take that feedback into making some finalized proposals. So that's coming up, as well as National Quality Partners, Antibiotic Stewardship Initiative, and like I mentioned, that was recommended in the National Action Plan, a potential condition of participation for by CMS in order to have antimicrobial stewardship programs. So now that it's really on the national scene, and we know we're going to have one of these in the future, what is antibiotic stewardship? And the way that I like to think about it is it's a systematic effort to optimize the use of antibiotics, to maximize benefit, to minimize resistance, and to decrease adverse events, which is sort of like an all-encompassing goal, similar to things like with infection control. So how do we go about doing this overarching goal? Well, first of all, it's recommended to start a program. And so the recommendation, CDC and the website, partially down here, with the Get Smart campaign, has a lot of links to help what to do to start a stewardship program. But these are the main elements. So leadership commitment from administration, a single leader responsible for outcomes, which is often a physician, either an infectious disease physician, or if your facility is really small, another physician who is very passionate about this. A single pharmacy leader, antibiotic use tracking, regular reporting on antibiotic use and resistance, education of providers on use and resistance, and then specific improvement interventions. What are these specific improvement interventions? So here's a list of many different types of stewardship interventions. It's not all-inclusive, but it gives a good idea. So on the far left, starting there, prospective audit with feedback and formulary restriction are really the two pillars, and I'll discuss those in more detail. It could require antibiotic indications so that we know why antibiotics are being given, develop guidelines and clinical pathways. I think that these are great. They can encompass not only treatment for C. diff, but also all the things that we've discussed today about prevention and infection control, education, dose optimization, IV to oral antibiotic conversion, these use of rapid diagnostics, as well as decision support tools. I think the reason that we're talking so much about stewardship today and what are these interventions is because stewardship and C. difficile are so integrally related. So we all know that previous antibiotic use is the predominant risk factor for C. difficile. All antibiotics carry this risk, and none of them are really excluded, but most commonly implicated are clindamycin, cephalosporins, other beta-lactams, and fluoroquinolones. So if you look at that list, that's like what most people get when they need an antibiotic. Use of combination therapy and long-term receipt of antibiotic therapy are also risk factors. So not only what antibiotic you get, but how many and how long. The other important thing is if patients have C. diff, if they continue on antibiotics at the same time you're trying to treat the C. diff, and that's been shown to increase the risk of recurrence. So some recommend that a diagnosis of C. diff be a timeout for antibiotic stewardship, just to really make sure that any other antibiotics on board are really necessary, in addition to addressing things like PPI that we've sort of mentioned today. And the reason antimicrobial stewardship helps with this is because it reduces unnecessary antibiotic use, it minimizes combination therapy, and reduces treatment duration, which all will help to reduce risk of C. difficile and improve outcomes. So what about community and rural hospitals? I think antimicrobial stewardship programs in large hospitals have really blossomed, and a lot of academic medical centers have antimicrobial stewardship programs in place. But if you look at the almost 5,000 registered hospitals in the United States, 72% have less than 200 beds. And these hospitals with less than 200 beds, most of these are without antibiotic oversight. They may not have infectious disease support. But the National Action Plan does not exclude hospitals based on size. And so they are going to need to be able to do antimicrobial stewardship as well. The issue being that there are very few studies of stewardship in these settings, and but we still need to do them. And one of the reasons is the rate of antibiotic use at these facilities is still high. So before we get into more information, though, the first polling question is: do you have a program for antibiotic stewardship in your facility? And so it looks like we have a good variety here. It sounds like the majority of people on the call do have antibiotic stewardship in your facility, but a number of people are in the process. So, have a partial program, working to launch a program, or maybe, hopefully, if the answer is no, thinking about potentially starting one, in the coming year. So I mentioned your antibiotic use rates are very similar. So here's looking at Intermountain Healthcare is a group of 22 hospitals within our health system, and excluding some of the really ones like our orthopedic hospital or pediatric hospital, they're all displayed here. And we have 4 large facilities that are greater than 200 beds, up to the 450 bed range, and then we have a number of hospitals, 15 here, that have less than 200 beds, and some of these have only 18 or 30 or 40 beds. And if you look at antibiotic use as a rate, so the facilities are all coded on the x-axis, but on the y-axis is days of therapy per 1,000 patient days present. You can see that these smaller facilities have the same rate of antibiotic use or more than even our large tertiary centers that have transplants. And so I think if you look at it that way, you can say, oh, okay, they need stewardship just as much as a large facility needs stewardship because their rates are so comparable or even more. And this data comes from the NHSN antibiotic use option. And so that's a really great way that I know is I think they're getting a number of people on board. There's already been a number of sites, 6 different platforms that have developed ways to communicate this data to the CDC, but I think eventually an eventual goal will be that we're all reporting antibiotic use data through NHSN to the CDC. So the main section today is talking about the SCORE study. So what do we do with the SCORE study? This is stewardship in community hospitals, optimizing outcomes and resources. So because there are, the majority of hospitals in the U.S. are less than 200 beds, and we want to know how to do stewardship in them as well, our objective was to define an antimicrobial stewardship strategy for Intermountain smaller hospitals that really optimizes outcomes while maximizing resources. I really liked the last presentation where he talked about there's like ideally things that you would really like to do if you had funding, and then there's the reality of what you can do with current resources. So we're trying to balance that here. So we looked at 15 community and rural hospitals, and we did a cluster randomized controlled trial. So program 1 was high resources, program 2, was medium resources, and program 3 is low resources. Now those actual numbers will change in the next slide, but we equally divide them into high, medium, and low. And the basic difference there is the high resources had infectious disease specialists, physicians, and pharmacists helping. The medium resources really relied on the central staff, and the low is basic requirements. So we did a 6-month curriculum development and then a 15-month intervention period. And if you look at our types of stewardship interventions, going back to this slide that I had in the beginning, there are 5 that we really focused on for this cluster randomized trial. And so that's the prospective audit with intervention and feedback, formulary restriction, antibiotic indication, education, and IV to PO conversion. So if you look at program 1, 2, and 3, and this is actually going to be different than how I said. So program 1 being low, program 2 being medium, and program 3 being high resources. We did antibiotic best practices for everybody. These are basics that we feel like this met, the CMS initial survey of the things that they recommended, and then basic antibiotic stewardship education. So this included access to ID clinicians and pharmacists. We had a hotline available, 48-hour antibiotic timeout, antibiotic indication, IV to PO conversion, and then a monthly hospital antibiotic utilization report. So I'm going to highlight these 3 here just to go into more detail about specifically what we did for those 3. So a number of policy and procedures are available. I mentioned dose optimization is another one in addition to IV to PO, but we created an IV to PO quick reference guide. So initially what this turned out to be was just an information sheet about what is IV to oral conversion, why should we perform it? It helps improve patient safety and mobility, or comfort and mobility. It can sometimes reduce length of stay and decrease, other complications associated with having a line. And then we have certain medications that are eligible. And initially what this was a sticker that they just placed in a paper chart for the physician to sign if they agreed with, the IV to PO conversion. And since then, we've worked to make this an automatic IV to PO conversion. So if patients met certain criteria, the pharmacist can automatically convert them over to oral. The other thing that we did was work on antibiotic timeout. And so interesting what we found is that sometimes physicians aren't always aware that their patients are on an antibiotic or which one that they're on. And so this is not really guiding what they should or should not treat with or how they should change therapy, but that the CDC recommends that you acknowledge that the patient's on XYZ antibiotics for this duration and then reevaluate. And so we created an automatic email generator report that went to the pharmacy directors so they could print it off for any patient who had more than 48 hours of antibiotics. And they could put that in the patient's chart as a reminder to the physician that this is a time to reevaluate therapy. And then the last is, I mentioned, tracking antibiotic use, which we do through NHS and AU options, and then reporting this back to facilities. So here's an example facility, one of our ones in the northern region is overall facility use, but then also broken down by units about how much antibiotics they're using on each unit. So that's kind of the basics that all programs had. And then if you look at program 2 and 3, there's some additional special things that we did. So we did advanced antibiotic stewardship education through these My Learning modules. And then they did prospective audit and feedback at a limited version in programs, the medium program and a full program and the high program. And then restrictions. We did do antibiotic restrictions. They were locally controlled by the pharmacy in the medium group, and then they were controlled by an infectious disease pharmacist in the high group. And then also in the high group, the ID study staff reviewed positive blood cultures on all patients and MDROs on all patients. So what are these prospective audit, feedback, and restrictions? I'll just go a little bit into detail about kind of the 2 different pillars. So pillar one being prospective audit with intervention and feedback. This is basically saying that you can use whatever antibiotic you want to use up front, but at that 48-hour point that the CDC recommends, we're going to ask that try to figure out a way to de-escalate. And so we really did an educational session about how to narrow therapy. If you started with a huge, big gun, how do you narrow to something that's just more targeted? And so we had this would be recommendations of conducting the physician and making specific recommendations that they would or would not accept. And then antibiotic restrictions. So we also came up with guidelines for these just so that we were consistent from person to person, but basically reviewed the criteria, and if the patient didn't meet the acceptable use criteria, then the physician was recommended a different agent to try instead, so that we reduce the the pressure of using these really broad agents. So here's our next polling question. Is there a person at your facility responsible to review antibiotic orders? So it looks like the majority of people do have a person at the facility responsible for reviewing antibiotic orders. And so, I think that's great. I think then coming up with formalized approaches for how we review these and recommendations, I think is then, really the next step for antimicrobial stewardship program. So here's the final slide just showing our data. So we're just in the midst of analyzing our data from the SCORE study. And so I'll show you our initial data here. So if you look here at the modeled rate ratio of all antibiotics, so this is looking at comparing pre and post antibiotic use. And you can see that the antibiotic use has not significantly changed in program 1, which was the low group. In program 2, there was some reduction in some of the hospitals. This was not statistically significant. But in the high resource group, there were 4 hospitals that reduced their antibiotic use, and 2 of them did so statistically significantly. And this overall, if you compare program 3 to program 1, there's a statistically significant decrease in antibiotic use, a 17% decrease in antibiotic use, with the intensive program compared to just the basic. And we also looked at restricted drugs. This is a very significant focus of ours, especially in some of these centers where we felt like they didn't really, their microbial sensitivity, their antibiograms didn't really suggest they had to use these big antibiotic guns, and so that's our rationale for utilizing them less. And so you can see here that all hospitals statistically reduced their antibiotic use, but the most reduction was in the high group where the restriction was controlled by an infectious disease pharmacist. But it was also very well controlled by reduced by almost 50% in the program that was controlled by local pharmacists. It's impressive here, Hospital 11 pretty much reduced their broad use up to almost nothing during the time of the study. And so you can see that there was more than a 50% reduction in these restricted antibiotics in the high intervention group compared to the basic intervention group. And so lastly, we talk a lot about antibiotic use, and this is one of the big discussions as well with the CDC, NHSN, AU option is, well, sure, we have overall antibiotic use, but should we care more about the category? So what if, they're using more, but they're using a lot of narrower drugs, and one's using less, but they're using, these very broad agents. So we did want to look at just patients who are receiving Category 4 and Category 5 drugs. So we looked at just these ones. These are like your anti-pseudomonal agents, your carbapenem, and your drugs against MRSA that are included in these Category 4 or 5. And what you can see here with our model rate ratios is that there was a reduction in the Category 4 and 5 drugs, which was statistically significant in the medium group, but trended but was not statistically significant in the high group. And so you can see that, ratios here. So I think that this is good. We're not just reducing overall use, but we're reducing, and some of it is because these were restricted agents in the category 4 or 5, and so restrictions are very effective. So score study conclusions. So antibiotic use in small community hospitals is comparable to larger facilities, so stewardship is needed. Stewardship is feasible in these settings, and stewardship can lower antimicrobial use. Which program type fits best is to be determined. And I'm sure one of the questions that you're asking as well is so we showed lower antibiotic use, but what about Clostridium difficile infections? And so we're in the process of analyzing that data, but I can tell you that we actually didn't have high enough rates of C. difficile pre-study that I'm not sure that any reduction is going to be statistically significant, but we're in the process of analyzing that data now. So in summary, antimicrobial stewardship is an important approach to reduce antibiotic resistance, including C. difficile. Soon, all facilities will be required to have an antimicrobial stewardship program in place and have it being functioning with specific standards that have been set forth by the CDC and other bodies. And then antibiotic stewardship is feasible in all facilities, but I do think that we, through the study, encountered many ways in which this needs to be tailored to unique site needs. So lastly, I would just like to acknowledge all those who were involved. So, the infectious disease physicians that I worked with, including Dr. Eddie Sinium, all the ID pharmacists within our group, our administration, Doug Smith and Robin Betts have been amazingly helpful, our pediatric ID partners, and then our statistical team and data support. And also just thanking all the providers, the physicians, and the pharmacists in the small community hospitals, because they really did most of the work here. So thank you for your time and attention, and I'm open to any questions that you have.
Thank you, Dr. Buckel. There's a couple of questions in the chat that we received. What are some of the ways the communities are looking at antimicrobial stewardship, aside from hospital programs?
Yeah, so I don't, you might clarify if I'm getting the right interpretation here, but I know that, there really has been a push that we should do antibiotic stewardship, not just within inpatient hospital settings, but also in long-term care facilities and in the outpatient setting. And I think that there have been some really promising studies looking in those areas, but it's very new, and so we don't quite know how to do it in those areas yet either. But I think there's definitely a need. And so I think, it's just looking at those different pillars and seeing, can you come up with a protocol? There may be some educational initiatives, but I think education is great, but, it's hard to maintain if there's particular staff turnover. But still a great option, and I think, I think that's definitely going to be something that people will be looking into going forward.
Great, thank you. And then one last question. How did physicians receive the feedback, audit process, and limitations on the formulary?
Yes, that's a great question. I think a lot of it, we had, before we did the 15-month intervention phase, there was that 6-month education program. I think that really the prep work leading up to it is really important, and trying to get buy-in. So we did a lot of site visits and met with providers and explained our rationale, and we really said for a lot of the restrictions, these weren't necessarily because they were doing, an awful job and need to be changed, or it was just really kind of going back to the microbiology, looking at the antibiogram, looking at, stratifying risk, and saying, hey, we don't need to be using this in all these situations. And so I think that people were very receptive. There were 15 different hospitals, you can see, and if you look at the data closely, there were probably some hospitals that were much more akin to adopting and being open to having those recommendations being made. And then there were some facilities that there was more of a struggle. But I think it's a cultural change that we really worked hard on.
Great, thank you so much. In the interest of time, any other questions that were left unanswered, we'll make sure to send them out to the participants today. So I'd like to thank Dr. Buckel. Thank you very much for your presentation and the wonderful information you gave us.